Hi everyone. Thank you all for joining. This is a webinar from the Global Observatory of Long-Term Care. Specifically, this is the first webinar from the Pain and Care Home Special Interest Group. Adelina Gomez Herrera is the director of the observatory, but unfortunately she isn't able to attend today. My name is Naz, and I work as a research partner at the GOLTC, and we'll be doing a quick introduction for the observatory. So the GOLTC is an initiative from the International Long-Term Care Policy Network. The idea behind the observatory is to harness the collaboration that many of us had through LTC COVID and now focus on tackling wider long-term care challenges. The aims are to be a platform for cross-national learning, so to identify key shared long-term challenges and showcase how different countries and localities are addressing them, and to share evidence and facilitate collaboration. So this is an area open to anyone interested in long-term care, including policymakers, industry, advocates, care professionals, and academics. This is a new initiative, and if you would like to engage, you can become a member here. I'll be sharing links in the chat as we go on through the webinar, as there are many ways to engage with the observatory, including sharing publications, country profiles, and joining special interest groups. But in order to do that, the best way is to become a member first, and that is free. In terms of our next events, specific to the Pain and Care Homes Interest Group, their next webinar will be on the 17th of September, and you can already register to join that on Zoom. And then for June specifically, we have a few other webinars, starting with 2 days from today on June 6th, the Long-Term Care Interest Group for Economics will be presenting. And then on June 11th, we have the Care Home Markets and Regulation Interest Group doing a webinar. And on June 24th, we have the Long-Term Care Policy Interest Group doing a webinar. Now I'm going to pass it over to the Pain and Care Home Special Interest Group to begin their webinar. Thank you so much.
This group consists of Sina Aldrich, Sandra Zwack-Harlan, and me. We had that vision that maybe focusing on pain in nursing homes, in care home, is a challenge for not only us in Austria, Sina in UK, or Sandra in Netherlands. And that's why we created this special interest group. We are happy that so many people are interested into the topic, into that webinar. And as Nas said, the next one will be on the 17th of September. And then it's on pain management in care homes. Sina, do you want to add something more?
No, I think you've established it beautifully, Manu, and it is good to see a lot of people taking an interest in this, because we know that it is so problematic and it leads to such poor outcomes for those people affected. So I think the more we can learn and improve this subject, the better for everybody.
So then I will introduce, or I will welcome Wilco Achterberg, our first speaker.
So my name is Wilco Achterberg. I'm from the Netherlands. I'm a professor of elderly care medicine, and I come from the city of Leiden, but I'm also a visiting professor at the University of Nottingham. And Leiden is one of the most beautiful places in the Netherlands. It's a very old city. It is not so tourist infested as Amsterdam, and has a very famous university, which is the oldest university in the Netherlands. And actually it was a gift by Prince William of Orange in 1575 to the people of Leiden, who withstood the French invaders for many years. So that's a very classical university, and you must visit Leiden. Patrick, you were in Leiden, and he can say that it's a wonderful place. But this is not the theme that I will be discussing today. I am discussing pain and pain assessment, and I was asked to have a introduction to the Pike 15 scale. And so, of course, the background is that the golden standard when we assess pain is self-report, and we do have a lot of instruments to assess pain. We have the visual analog scale, the numeric rating scale, verbal rating scales, faces pain scales, and all kinds of other with colors, etc., thermometers. But if you look at those scales, you can see these scales, they refer to some abstract thinking. And of course, when we look at patients with dementia, abstract thinking is one of the issues that is not working as should. And indeed, Sophie Potin, a researcher from Switzerland, already showed us in 2006 that the most used verbal rating scales, like the numerical rating scale, the VAS, and the faces pain scale, are not understood by most people with dementia. So that is an issue. But of course, there are other ways of assessing pain. And one of the things is that we can use non-verbal responses to pain or non-verbal expressions. And of course, when you have pain, you can see some changes in body posture. You can see changes in the facial expression. And of course, people do have other vocal responses to pain, which are not only with words like moaning or screaming, etc. And indeed, in the last like 30 to 40 years, these kind of non-verbal expressions have been put into scales in observational pain instruments, and you can see some of them here. For instance, the Abbey pain scale it's used a lot in the UK. And if we look at the PayNet or the PAC/SLAC, it's used a lot in other countries. But the thing was that although these scales have been developed based on knowledge and experience, the further validation and development, well, it was limited. So there's limited validation. And there were also some concerns about parts of all of these instruments. And so in 2011, researchers from all over Europe, they came together and said, well, we want to make out of all of these observational pain instruments, the best pain instrument. We call it a meta tool. So we're going to look at all the evidence, all the evaluations of the items, and we are doing that with the criteria of the Cosmin group, which say, well, if you have an instrument for a health-related problem, then you should look at reliability, validity, responsiveness, and interpretability. And so we went together, and in 4 years, we developed an observational instrument that we call PIKE. And so it's an instrument that's used in clinical settings, but also in research. And now I will have a short introduction video about the PIKE. I hope.
In order to recognize pain in people with dementia, the so-called PIKE scale has been developed. PIKE is an acronym of Pain Assessment in Impaired Cognition. Using the PIKE scale, you'll be able to track indicators of pain in people with dementia in a systematic fashion. The scale has 3 domains. 1. Facial expressions, such as frowning and narrowing of the eyes. 2. Body movements, such as freezing or resisting care. And 3. Vocalizations, such as mumbling
no.
or shouting. Each domain consists of 5 indicators of pain. After you've observed the client attentively, you score each indicator. For example, frowning. If you haven't observed frowning in your client, your score is 0. If you've observed a little bit of frowning, the score is 1. For average frowning, the score is 2. And for heavy frowning, you write down a score of 3. If you, for whatever reason, cannot see the face of the eyebrows of a client, you use the last column. Work your way through the 3 domains. The higher the score, the higher the probability your client is experiencing pain. Not all clients express pain as clearly or in the same way. By observing attentively and writing down the pain indicators systematically within PIKE, you'll be able to recognize pain in people with dementia more easily.
So this was the introductory video. Well, so what we did, we looked at the items of the skills that already existed. We did item reduction. So we looked at the empirical reliability data. We also did qualitative item reduction. We looked at construct and criterion validity and responsiveness. And then we came to this PIKE 15 scale. And here is the PIKE 15 scale, which is in English, but it's also available in around 10 other languages, such as Chinese, as you can see here, but also, and Patrick is going to talk about that, in Brazilian Portuguese. So this really helps us, because why is it so important to have a good observational pain scale? Is that we see that people with dementia, of course, we know they have functional impairment in the course of dementia. They also have behavioral changes like anxiety, depressions, agitation, and falls. But we also know that pain can lead to functional impairment, and also pain can lead to behavioral change, to anxiety, to depression and agitation. And so if we want to take care of people with dementia, we should be aware of this. We call it a diabolical triangle. And so PIKE 15 should be used, for instance, in implementation of management plans for pain and challenging behavior. And so we did some studies in that we try to engage in good management for behavioral problems. And then an observational pain instrument like the PIKE 15 is very, very important. So the interesting thing is that we have a very good website for the PIKE 15, which is free. So at pike15.com, there's also a free e-training in English, German, and Dutch. And you can look for the forms in your language. It's also freely downloadable. And also at the website, you can find references on, for instance, the psychometric properties of the PIKE 15. I'm very glad that every year there's much more international attention for, and also more languages available. So, of course, I told you my name, and I'm not going to tell you all of my co-workers, which I heavily rely on, and which I always like to thank for their tremendous work.
Thank you very much. And as Wilco already said, the PIKE is available in different languages. And now I'm giving the floor to Patrick Wachholz. He will be talking about the Brazilian version.
Thank you very much. My name is Patrick Wachholz. I'm a geriatrician in Brazil, a collaborating professor at Botucatu Medical School. And we have the pleasure to meet Manuela and Wilco during a workshop in Brazil called Lotus. And then we consulted Wilco and his team about conducting a translation and a cross-cultural adaptation of the PIKE to Brazilian and Portuguese. So the part one of our job was exactly doing the translation and then the cultural adaptation. So the original English version was submitted to forward translation into Brazilian Portuguese by 2 independent translators whose native English was Portuguese. One was a healthcare professional with expertise in treating pain, and one was a healthcare professional but without experience in treating pain. After the first forward translation, we invited 6 healthcare professionals with clinical and research expertise and qualifications in treating pain and people living with dementia, with Brazilian Portuguese as their native language and English as a second language to compare both translations. And then they made the face validity assessment, looking exactly for items, clarity, suitability, and the tools' idiomatic, semantic, cultural, and conceptual equivalences, and proofreaded a first draft version. This first draft version was back translated into English by 2 independent translators who were native to English, but they have Brazilian Portuguese skills. The same 6 research judges reviewed, compared, and compacted the 2 back-translated documents into 1 second draft in English, and then we sent to the authors of PIKE 15. All disagreements were discussed and adjusted in an online meeting with the research judges and the PIKE authors, and then we have a third revised version. This new version was presented to 3 we call them nurse judges. They were experienced in caring for older adults, and particularly older adults living with cognitive impairment. And they were invited to a Think Aloud session. During the Think Aloud session, they discussed about their perceptions of each item, and they can rely on their experience and their perceptions to be included. And then we took notes about all their perceptions. So we had the forward translation, the research judges, the backward translation, the nurse judges to then draft a final version of the PIKE 15 Brazilian Portuguese version. We then performed a content validity about this new version. It was circulated through email, social media, and instant messaging app like WhatsApp, and also among the participants of the Brazilian Conference of Geriatrics and Gerontology in 2023. And we invited healthcare professionals older than 18 years experiencing caring for older people with pain and cognitive impairment to answer the survey. And we call them clinical experts. We also had a particular group among clinical experts who were nurses and geriatricians working in long-term care facilities. We call them target users, not because this tool was supposed to be used only in long-term care facilities, but we understood that they perhaps may be the healthcare professional that will use most this tool. So clinical experts answered 5 questions to assess their personal characteristics. And they were asked whether they consider each item of PIKE 15 to indicate pain using the Likert scale, with 1 means no, definitely not. No, 2 means no, probably not. 3, yes, probably. And 4, yes, definitely. They could indicate whether each item was specific to pain or if it could be a symptom or a behavior related to other conditions or disorders like anxiety, depression, or annoyance. And they were invited to include commentaries regarding their perception about the tool. So we made descriptive analysis, a content validation coefficient, and evaluate the specificity for pain. And this is what we found. These are the items in Portuguese. Perhaps the graphics are easier to understand. Here we can see the content validity coefficient from each item of the PAIC 15, from frowning, from narrowing eyes, from raising up lip, and 0.8 was considered a good response for this content validity coefficient. The second graphic shows the number of participants who perceive the items of PAIC 15 as specific for pain, dementia, anxiety, delirium, depression, or other conditions. And the blue line represents 50% of the participants' response. And this last graphic shows the number of target users, geriatricians and nurses who work in long-term care facilities, who perceived the items of PAIC 15 as specific for pain, dementia, anxiety, delirium, or depression. Again, the blue line represents 50% of the participants' responses. And here we have a final table comparing the answers from a previous Dutch work with the Brazilian answers, particularly here focusing on the target group that we define as this Dutch research also have a target group, the Dutch nurses working in long-term care facilities and the elderly care physicians working in long-term care facilities. And you can see that we have disagreements in some items, but most of them were in agreement with the Brazilian and the Dutch version. We understand that there are some limitations in our research. The tool has yet to be tested in clinical practice, and larger samples to include other psychometric properties. The participants were guided to choose only one option about the specificity of the items, so this could hide part of their opinion. We found difficulties in reaching an adequate number of nurse technicians who directly looked after older people living with dementia at long-term care facilities. And in the Dutch version, only the long-term care specialists participated in the research. Both groups sought restlessness, shouting, and resistance were not specific to pain. We included specialists in caring for older people and professionals who assist older people and adults, and a reasonable number of healthcare professionals with different expertise in pain, which may be why we faced some discrepancies when compared to the Dutch research we mentioned previously. These are other tools. It's because we prepared this class for another group, and this is something I found it very interesting because it's something like using PAIC but with artificial intelligence. I am not sure if we will see this happening so soon. I hope Wilco can tell his thoughts about it, but it seems something interesting. Then I end here, and thank you for your attention.
I'm happy to chip in, Manuel. I think for me it's really fascinating the difference between the Brazilian findings and the Dutch findings, and I wonder if we looked more broadly internationally where we'd see differences again because of the setup of healthcare provision to or residents in care home. For example, in the UK, we have a very, I would say, almost dysfunctional arrangement in how we support people in care homes, in the fact that we are supposed to have primary care practitioners supporting people with incredibly complex needs, often without the skills and perhaps experience in dealing with people with complex presentations, and whether we would see even differing results as a response to that. Because I wonder if when you explore this with people who are highly skilled in their roles, some of it is perhaps a bit more intuitive for those who are less skilled. So I don't know what your thoughts are, Wilco, Patrick, on that.
We did find some things that were very interesting. For instance, we know that we have facial expressions, body movements, and vocalizations, and we know from laboratory research that facial expressions are very specific to pain. So that should be the best part of the observational pain scale. But the interesting thing is when we did the testing, we found that nurses were not used to look at the face of the patients when they took care of them. So in transferring, etc., they were not trained to look at the face. So that's one thing, the training. The other thing is that there are some differences in expressions of pain, not in the facial expressions, which is really a lot of research on that. It's really in all cultures about the same muscle groups. But if we look at body movements and vocalizations, of course, that's different. And also in the presentation of pain can be very different. For instance, Brazil or Japan is very different. And people are also, they have learned behavior. So that there are cultural differences, I think it's we acknowledge that. We did try to lose the most items which were most culturally sensitive, but I do think that we could have done a little bit better. And in fact, we are now with some of the original developers also reducing items in this Pike 15 and go to a Pike 6, in which we lose all this cultural bias, etc. And so I think our newest developments will help with this. I'm not sure. What do you think, Patrick?
Yeah, I agree with Wilco. What we observed during this process is that the more common situation is the nursing taking care of the patient while the doctor was observing the nurse and the patient's facial expressions. So I'm not sure if this is what happens, but yeah. And this last slide I show about artificial intelligence showing how face expressions can be tracked is something that's intriguing me, because I am not sure if this limits or amplifies the properties of using facial expressions as indicators of pain in people living with dementia.
Yeah, so this I see Martin Smalbrug is also here, and Martin did some co-authoring also on this system, this app, which uses automatic face expressions. Actually, it's not only the facial expressions, but it's also the Abbey Pain Scale, which is incorporated into this app. There's only one problem, and that is that the facial expression software has become very widespread in the last years. Most iPhones have facial recognition, but the problem is that most algorithms are not used to older faces. And so even in the first facial expression recognition software, they couldn't, these kind of algorithms couldn't even recognize a face of a very old person as a face, let alone interpret these kind of expressions. However, we should acknowledge that software is getting better every day. So this really is something that could be very helpful. And there are some studies, maybe Martin, you can say something about it, I think it was New Zealand, in the care homes, which showed that it was feasible, wasn't it?
It was at least feasible, but as you said, the algorithms are not open and clear. That's one problem. And also the phase of is between a Dutch person and a Japanese person. And in New Zealand, you have different kind of persons. It's not always the same. So there has some development to be done in AI algorithm forms, I think.
Yeah, it's promising, but not the golden grail.
Not the golden grail already. Yeah.
Can I ask a question? When you think about using this app for the facial expression, and now Wilco, you on the side are in the development of the Pike and shorten it, and then we have this pain, the pain episcale. Do you also think about maybe making Pike into such an app? Because when you have a meta tool, shouldn't it be used as a standard tool? So what do you think about that?
Yeah, I think that we should definitely test that, but that's something that we have not planned yet. But it's certainly I had a few discussions with the developers of this software, but we have no definitive plans yet.
Okay, so future plans to go. Perfect. Maybe the other ones, are there colleagues here around who have also experiences with using the Pike in which version ever, in which country ever?
I have to say, I think in the UK, Manuela, we're still using the Abbey Pain tool, as Wilco pointed out, quite a lot, particularly in residential care settings. And I think there is definitely something about having it digitalized, because there are so many apps that are being brought into the care system now with different tools and things like that on there, that I think it would make it perhaps more accessible to a lot of care providers where it may not be now. Because I think one of the challenges is about upskilling and training staff to be able to feel confident and competent in using these tools. And I think whatever tool one adopts, that always is a great challenge. And when we look at the size of the facilities, or the amount of facilities we're looking at across our nations, we have to reach a lot of people in order to embed these tools. And we know the workforce is very transitional, and I'm assuming it's very similar in many other countries where, people don't necessarily stay in care homes as a long-term career plan. There's a lot of staff turnover. So once you embed something, you almost have to continually keep embedding it. And I think that's always a real challenge. But this accessibility through existing digital formats and linking it to perhaps care planning facilities, etc., that are already starting to come on board into care homes, I could see that being a real benefit actually, in taking this forward. Because as a clinician, I still see people saying that people with dementia don't have pain, or changes in behaviour are automatically associated with a diagnosis, as opposed to, the fact that someone with dementia might have other things going on and comorbidities and that. So I think anything we can do to scrape away and change that narrative is really, really critical. They're just my observations. I'm sure there's others on this call who are equally experiencing that, both clinically and from a research perspective.
Yeah. I'd like to add that what we saw and what we see is that implementation of this observation scale, of course, seems very important. But what we found is that we get a lot of feedback from nurses, especially nurses who do this e-training, and they also do this e-training in their team. And so one of the positive effects is that they talk about non-verbal behaviors, and they discuss what can it be, how should we manage this. So maybe the highest impact is something that we did not think of beforehand, that it drives team training, it drives awareness of the problem, and it drives discussion. Because of course these to observe behavior is always like a little bit subjective, and we should encourage people assessing it, discussing it, and discussing it with physicians and in your team.
Did you use case studies at all, Wilco, to expand on that? Because I think when I've worked with care home staff, whether they be qualified or unqualified, when you try and teach them, I think when they have case studies that they can familiarize themselves with, it feels more real, and I think they grasp the concept more readily.
Yeah, we didn't do it, but luckily Sabine Kruijer is also here, one of my PhD students, and so maybe that's something we can do also, Sabine.
Recently, I have been doing a research in the long-term residential homes in Denmark, and I have been working with dementia. But the professionals I have been interviewing, they're the one who have shorter education in the system, like a healthcare assistant and helpers, we call it in Denmark. I was wondering, have you considered this group of health professionals? Because in the care facilities, there is maybe only one nurse working the whole unit, and the helpers and assistants, they are the one who are in contact with the I will say patients or dementia residents all the day. So they are the one who will notice the facial expression, or they will notice anything which is different within the residents first. So have you considered this group of people, because they are the one who is in need of most education, I will say.
Yes, thank you, Jahan. It's a very good question. In the process, in this 4-year process, we did a lot of throughout Europe, and we used this scale in students, in low educated staff in both nursing homes, and also in informal caregivers. And so also the training results are not very different from people with more education, because it really refers to some basic observational skills that you as a human have.
So will you consider that this sort of using tools will be for the training in the system, or will it be included in the education? How will you recommend it?
Yes, so that's something that we try to establish, that it will be part of the training program. It's not very easy to change training programs, is my experience, but it will certainly help. And one of our experiences, and that's also, for instance, the case with other assessment instruments like the minimum data set in the USA, is that people who have not so much education, they really like having their observations in a number or figure, so that they feel they have something they can discuss it with the doctor, for instance. And so if you have difficulties expressing what you see, then this really helps. So I think the highest gain is in the lowest educated.
Thank you.
Yeah, we have also used it in a small project, the PIKE, but only in 4 or 5 nursing home residents. And I was wondering, and this is now a question to every one of you. At the end, you have the sum score, and the higher the score, the more the probability that the person has pain. How do you deal with that? So how are you discussing then the results when you have this assessment?
I think so. There is a cutoff score now by Jenny van der Steen, that study. So the cutoff is between 3 and 4. But of course you should discuss it, and some people asked us also, can you give an algorithm? If the score is like 3, you give paracetamol, and if it's 10, you give opioids, which would be helpful. But we do not endorse that. We do endorse to discuss the scores in the team and also with the physicians.
Is there something about educating the physicians as well, Wilco? Because I know that can be a real challenge for care home staff is using these tools and wanting to advocate for their residents and those in their care, and then persuading perhaps doctors to prescribe, and sometimes there's that reluctance to prescribe pain relief in older people. And I don't know if you came across this. I certainly see it again in clinical practice, where even, you know, to get clinicians to prescribe regular paracetamol, for example, rather than as required paracetamol, can be a challenge. And I guess it's, again, how different systems adopt these processes in a way that's, you know, useful. And you know, I've seen the Abbey tool, pain tool, used really, really effective, and I'm really keen to explore this tool further in our practice, because I think one of the challenges is the care home staff, unless they've got a reciprocal health system that supports them, sometimes it can still mean that they'll identify something that doesn't get resolved. Does that make sense? Sorry, I'm probably not putting that very clearly.
And it's a pity that Sandra Zwakhale is not here. In, I think it was 2012, she did a study implementing the PAX-LAC, which is also an observational pain study in long-term care facilities. And what she found is that nurses loved it, and they gave the results to the physicians, but the physicians didn't do anything about it. And I think that counts for a lot of issues, for a lot of themes, is that probably the most effective training is interprofessional learning. And so we did some, also we have, of course, guidelines for pain, and we did some implementation studies, and we used interprofessional training, because if the doctors do not understand what it is about, then there will be a communication issue, and of course an issue of ill management.
So the challenges within the interprofessional team, we also experienced this here in Austria. I totally agree what Wilco is saying, and Sina, that you have to just get the hold and think about that. But I'm also thinking about, there could be a structural solution. For example, if there's an internal rule in an organization, in a care home, when there's a PIKE score, like, I don't know, 4, 5, 6, 7. So there are also structural possibilities, I think, to go into that direction, because sometimes, and it doesn't matter if it's doctors or nurses, they are training resistant, I would say also. We did it the last, I don't know, 10 years this way, so why changing? Nevertheless, I think, Wilco, it's a perfect thing with the 6 items, because the shorter it is, the more feasible. And the more feasible it is, the potential to use it really easily and quickly in long-term care in a decade of nursing shortages is brilliant. So thank you from my point of view.
Yes, and the publication is it's almost submitted, so you can hope in a few months.
Thank you. So do we have more questions, comments?
I think there's a comment in the chat, Manuela, from Lisa, saying that there are such a variety of tools in use, it causes confusion for staff who move around different facilities, and perhaps different providers and organisations adopt different tools. And I think that is fair, and I think Wilco's slides demonstrated the volume of tools that there are out there, and perhaps a lack of consistency in the adoption of those. So I think it's an absolutely fair point, and it's something that, you know, from system-wide level decision makers, we need them to kind of agree what might be the best tool to take forward in these environments, mightn't we?
So I absolutely agree. This is something where we have to get now and think about it. For the long-term care setting, do this for people with cognitive impairment, dementia, or use this scale for that, because right now it's a huge number of instruments, and there has to be a decision, because without the decision they are insecure. And as Wilco said, such recommendations or checklists or whatever help them to work and also help them to communicate within the interprofessional team. Yeah, so there is, I think, a lot of work still left to do. Yeah.
I guess one of the benefits of having a group like this is potentially we've got a lot of other people who might want to get involved with some of the research that's ongoing. And I think we've already posed a problem in terms of the case studies that Wilco's picked up on. So it feels like this group, as we progress, might be a real opportunity to answer some of those questions or encourage people to consider those questions more proactively.
Thank you very much for your wonderful presentations. I'm interested in pain assessment in older adults. And may I ask a question to Professor Wilco? Notice that you have Chinese PIKE 15, but I did not find any manuscript or article published regarding Chinese version.
So my colleague from Groningen, Professor Sietse Zuidema, he's also a visiting professor in I think Xianying. He did a study on the PIKE 15, so translation. It was in patients with dementia and patients after stroke with aphasia, and so it's submitted.
Oh.
So the paper is submitted, and so I was in China, and I had in October this year, we had presentations on the PIKE in Beijing and Shanghai. And also in Hong Kong, and the Hong Kong universities and hospitals are very interested in implementing it. So
yes.
So it's becoming a little bit more known now in China. Yeah.
Actually, 2 years ago we are starting a project, but just but not got funded. So we just implementing, and now we are comparing 3 pain scales, pain 80, I know, you know, pain 80, and morbid 2, and PIMD, PIMD. You know that?
No.
A newly one. Yeah, this is a new one.
Okay, yeah.
Yeah. So at first, we are just considering about selecting 3 scales, these 3 scales, but now after today's, your presentations, could we use your PIKE?
Yes, yes, the PIKE is free to use. And so you can download the Chinese version from the website. And you can also use the e-training, but the e-training is not in Chinese, although my colleague, Sietse Zuidema from Groningen, has an e-training with Chinese subtitles. So if you want to use that, you can use that. And he's glad to send it. So we have the e-training with Chinese subtitles, and you can use it. It's an EU project which stimulates open science use.
I thought I thought there was no publication regarding the Chinese version of PIKE.
No, so it's upcoming.
Okay, so then do we still need to translate? Do you know what population it was tested?
Yeah, in people with dementia and stroke.
I mean, in the hospitals or long-term care? Okay.
Yeah.
Thank you so much.
And so if you send me a mail, I can bring you into contact with my colleague.
Okay, that's great.
Yeah, so maybe shall I put my email address in the chat?
Oh, that's wonderful. Thank you.
And then so we can...
It's good that PIKE 36 from 36 to 15, that's much easier to use in the clinical setting.
Yes, and from 15 to 6 would be the next challenge.
Yeah, that would be great.
So I think we have seen now through Wilco and Lily that these webinars are open for international collaborations, getting results from one part of the earth into the other one, and being open for just communicating with all around the world. So I think this webinar is a success.
Yes.
I can say it like that. So Nazan, I think we should say goodbye.
Thank you very much for hosting, Manuela.
So, Sina, do you want to close the session?
By all means, I'd just like to say thank you to both Patrick and Wilco for really starting a fantastic conversation and actually underlining that there's hope. There are tools coming forward. It's being researched, and I think for me as a clinical academic, it is so great to see that there is something tangible moving forward in something that is such a disruptive and underserved part of clinical practice, both in long-term care settings and more broadly in this population. And I'm really looking forward to further conversations in September to start to continue this conversation and take it forward. And as you said, Manuela, the fact that we've got such an international group here and that opportunity to have conversations that we might never have without these kind of forums, I think is fabulous. So I'm really grateful to be part of this, and I can't wait to see where it takes us. And certainly it would be great to have conversations outside these webinars, should we want to partner up and engage in a way that is meaningful to those people that we want to prove outcomes for going forward. So thank you very, very much. And obviously thank you to our hosts at the Global Observatory for enabling us to have this this group together, because I think without those forums it's very difficult for us to be able to facilitate these sessions. So thank you all.